All right, meeting has been recorded. Once again, good afternoon. My name is Dr. Oluwatosin Olateju, one of the co-chairs of the Commission on Public Health. Welcome. We are so glad that you joined us today. It's warm outside. It's always nice when we gather for those online. We're very, very appreciative of you taking the time every month to join us for this critical meeting. Today, I'm joined by our co-chairs, Dr. Mina Brewster and Dr. Boris Lukshner from the University of Maryland School of Public Health, and Dr. Mina is from St. Mary's County Department. Also joining me is Chidoben, our support staff from Morgan State University. We also have Shane here, and our senior advisor. We also have Sarah. We have our executive team. We have Shankar in the room from University of Maryland, our lead advisor from University of Maryland. We have several people here. We also have our commission members in the room. Thank you so much for joining us today. And of course, commission members online. Once again, just for the purpose of recording, by continuing to be on the call, you're agreeing to being recorded. Please note that the meeting materials are online. We'll continue to provide advanced notices on how you can dial into our meeting and access the meeting materials, which can be found on our website, which is https://smchd.org/commission on public health. Also follow us on LinkedIn. Just type Commission on Public Health, you'll find us there. In the interest of time, we're going to start with roll call for the June meeting, and we'll go over the meeting materials subsequently. So now I have Chidoben please assist with the vote.
Please, if I call your name, you can just say, I'm here, or, you can raise your hand so that I can take note of that. If you're online, you can also indicate with raise of hand so that we can also take note of that. And Chris Brandt, thank you. Mina Brewster,
yes.
John Drummond, Boris Rushner,
I'm here.
Oluwatosin Olateju,
Here.
Frank Philip, Nico Rochester,
Yes.
Mura Rosman, Richard Spencer,
Present.
Alan Twig.
Michelle Spencer, if you can just unmute.
I see.
Okay.
Thank you. Ida Bagnell. Nalis Kayanaraman.
Present.
Alisa Lord. Camille Blackford.
Here.
And Ariana Kelly.
Representative. Nilesh is online. Okay.
I don't know if our audio is working.
They can hear, but I don't know that.
Here, Nilesh, for
Yeah,
You can beat it.
maybe they were muted.
I'm here.
Nilesh, can you please say hi? Oh,
I'm
hi.
here.
Okay. I think they can hear us. Okay. Just make sure. Right. Okay. While we continue to work on the audio so that people online can receive feedback from the room, move along. For the roll call, unfortunately, we're not going to be doing roll call of non-commissioned members or members of the public in the interest of time. But just know that your inputs are valuable. We want to say thank you to members of the public that continue to join our meetings, whether monthly or join the work groups, respective work groups. We really appreciate. And to the members of the public for sending in your comments, for coming to the listening sessions. We do not take this for granted. We will not be monitoring the chat box during our meetings today for questions, but know that public comments and questions are highly encouraged, right? And it should be directed to our general email, which is md.coph@maryland.gov. You can also again submit your public comments, okay, through the link. You can find that on our website on the LinkedIn page. If you ask questions today and you're a non-commissioner, right, or a member of the public, and if you ask a question and in the interest of time we're unable to get to you, please forgive us in advance. I apologize. We might not be able to get to all the questions at the time scheduled today, but again, send us your questions and comments to our email. All righty. Conducted the protocol. Now, Do we have a quorum? Yes, okay. All righty, thank you so much. The quorum is defined as at least 50% of our commission members present. All right, next on the agenda is adoption of the agenda. All right. For commissioners that are here in person and online, the agenda, you can find it online. You can also please advance the slide right there. That's the agenda. You can also find it online. We have it printed. Please grab a copy. It's in the room. This was also emailed to commission members. Please take a minute to review, okay? Just want to make sure, just to know what those going to be for the day. All right, I would now like to entertain a motion to approve the agenda. All right, thank you so much. Camille.
Is it okay if we ask somebody online?
To speak, okay, sure. All right, so Camille makes a motion and Mina moves. I'm sorry, Mina seconds. Can I please have somebody online speak? We just want to make sure that we can also hear you.
Hi, thank you, Tulsa. It's Michelle.
No?
No?
All right. Okay. Apologies for that technical difficulties beyond our control. All right, it looks like we can hear audio from here, right?
I won't be hearing.
You'll be hearing? Oh, okay, okay. You can, okay. So we can use this temporarily, right? So can you unmute, please, and have somebody say something again?
Tulsa, we can hear you clearly online.
Perfect. I just heard you, Michelle. Thank you. All right, we'll use this temporarily until we're able to use the one in the room. Thank you. And this is what we do in public health. We make things happen, right? That's it. We make it happen, right? All right. So we need any discussions about the agenda or any questions? No, look down around the room. Grace, okay. All righty. So all in favor, please say aye. Right? Okay.
Yes.
Any nays? Abstentions? Right? Those online, please, if you're a commission member, please raise your hand if you're in favor of the adoption agenda. Yeah? That's okay. Thank you so much. All right, thank you. All righty. So the motion is approved for the adoption of the agenda. All right, moving along now is minutes review for May. Okay. You can also find that online. It's posted. We have copies in the room. Please take a minute to review the minutes. And we're reviewing minutes for May 2nd, May 10. It's also in your packet here. All right, I'll give like a couple minutes. All right. Okay.
Right.
I would like to entertain a motion to approve the minutes or there's no it should be on the
I
yes.
moved to,
But if not, it's for the second. I mean, right? Website.
yes.
Right. Yeah, it's fine. I didn't think that. Oh, no, it's not, okay, so you can find it on the website and it was emailed to all of you. All right. So it's right here on the screen, just take a look at the names and on the minutes. Right there.
Yes.
And someone else, something came forth for geographic. All right.
Hi. I just wanted to let you know I'm here about 10 minutes away. See you soon.
Are there any discussions about the minutes or requests for amendments? Okay, so let's start. Vote all in favor? Approving the minutes, aye. Aye? Yeah. All right. All right.
Bye.
Any nays or abstentions? Thank you so much. What about those online? Our commissioners online? Any questions, elections? Okay, I got a question. And please, if you have a question about it, make sure you unmute. Okay, it looks like, there is no abstention or anything. All right, great, the meeting has been approved. Thank you so much. This is a wonderful opportunity to acknowledge our special guests, right, for this month. We have with us Dr. Scott, who will be introduced in a minute. We also have Dr. Ben Steffen, from Maryland Healthcare Commission. The rest was from Maryland Healthcare Commission. She's not a stranger to us. At this time, I would like to pass it over to Boris, Dr. Boris Luchance. Please introduce the rest of the facts. Thank you.
So we're not gonna read that. See, the famous person we do have here.
Right.
And last at the University of Maryland College Park, public health commencement a few weeks ago, where Dr. Herrera Scott actually, she had told me she had never done a commencement speech before, and in 1 week she did two, sort of. One was Monday night a few weeks ago, where we're all lined up in our regalia and ready to march out at the Xfinity Center, 400 graduates and thousands of people in the audience, right, to see these graduates off and the lights went out. Yeah, and we actually had to cancel. And Dr. Herrera Scott was there.
As was my daughter.
As was, and that was sort of, and what do you say as a dean? It's like, we do everything in public health. And the fact that her career path, she has done a lot. But neither she nor I were ever trained as a. That's where it came. The following night, we did take two, round two. Dr. Scott was kind enough to show up again. This time, unfortunately, her daughter was not. He gave us a rousing speech. She is the Secretary of Health for our wonderful state of Maryland. She's also a former Chief Medical Officer in the City of Baltimore's Health Department. She's done a bunch of things. Executive Vice President of this and that, Vice President of this and that. Also a veteran of the United States Army Reserves. We see a service-oriented person, right? Not only in the private sector, service-oriented person at the city and state level. It's my pleasure as a co-commissioner to have you here with us today. This commission, as we discussed on more than one occasion, is about public health. Commissioners that you see around this table, and we have 32 people on the screen, which is not only shows you the sense of the commissioners being active in this, but members of the public, members of our working groups, right? Want to do things, want to be able to look at the state of Maryland as a role model. We're so happy to have you as so, Dr. Herrera Scott.
Thank you, everyone. It's great to be here. So I will jump to the slides. I should say on my veteran status for those of you, and I'm going to date myself, but some of you will take the reference. I was for the private Benjamin. And I did deploy overseas on the third time. And I was the person that was arguing with my commanding officer saying that I shouldn't have to carry a weapon because under the Geneva Conventions, I would be perceived as an enemy combatant. So how well do you think that went? I was told to quote unquote shut my pie hole and qualify the weapon. I did, but I said if docs are shooting their guns here, Boston, it's time to go. So anyway, thank you for having me. So if you go to the next slide, So I'm going to talk just high level on the role of Medicaid, building Maryland behavioral health continuum of care, state health improvement process, population health, and moving to our ideal state, and then the Maryland model, which is our global budgets, and then the new guidance from CMMI that we're working on. I am going to try and tie everything back to public health and for public health functions. I want to be clear that throughout this document, I'm not going to mention equity through health, but equity is core to all of this work. So if I don't mention it, it's not because it's not important. It's just it's embedded in everything. So next slide. So I think sometimes people forget about the role of Medicaid. They think of it as a public payer, but I really try to get people to understand just its role as an anti-poverty program, and that's relevant The governor has been so focused on childhood poverty and, a bill passed this session in support of this work called the Enough Act, which is really how do you take a policy and all approach to address childhood poverty. So I'd like to remind people, this is data that came out of the Georgetown University. One study tested the impacts of health insurance programs to non-health programs. So using social insurance means tested cash and in-kind benefits. So the kinds of things that we normally see from human services. What they found is that this benefit, health insurance benefits, accounted for almost 1/3 of the poverty reduction from public benefits for individuals and households without a disability recipient. Now, also, the effects were even larger in reducing childhood poverty and reducing poverty of color. More than half of all adults enrolled in Medicaid and more than 2/3 of children in Medicaid and shared are people of color. So for marginalized populations, Medicaid as an anti-poverty program is one of the most important programs we have in this. And as many of you know, during the public health emergency, we stopped doing redetermination. So people in Medicaid have to go through and verify their eligibility once a year, which we are fortunate. Some states it's quarterly, biannually, but we only have to do it once a year. But that all will shut off. We had 1.4 million people on Medicaid. It grew to 1.8 million people after the public health emergency unwinding. And then the federal government said, you got to now redetermine everyone. And for some people, they had never done that process. They had enrolled, but had never had to verify their eligibility. And people moved during COVID. So it was not only working with our managed care organizations, but finding everyone so we can ensure that people maintain their coverage as much as possible. Maryland was one of the leaders in this space. And you had an option to take 6 months and 12 months, and we took 12 months, and we were pretty successful. And I don't have the exact number, but it's 1.6, but we managed most of the people enrolled in Medicaid. We use some waiver authorities that CMMI granted, but we're very successful compared to several others. So next slide. No, one more. All right, let's go Medicaid plus. Okay, there it is. So, early on, we had an offsite with the leadership team, and we said, well, what are the things that we want to prioritize for this administration? What are the things that we think as an agency that we want to use as our North Star? And, these goals were specific to Medicaid, but then were applied to all the administrations. But we certainly want to lead with innovation and access with targeted efforts to expand coverage for care and services through a variety of policy makes. As many of you know, the Healthy Baby Equities Act passed last year, which allowed for people not documented in the U.S. to be able to obtain postpartum coverage. The budget only allowed 4 months, but it is an enhanced benefit. We are now have continuous enrollment for children. For our MCHIP beneficiaries, we used to charge families a copay. This was a hardship for some of our families. When we looked at the cost of the program to run and capture the premiums and the premiums that families were paying, we were like, okay, we can figure out how to make up that delta and not charge families premiums. So we got legislation to eliminate the premiums. So we are doing what we can to keep people enrolled, but it goes to how do we improve access and how do we innovate so we can improve access. And as many of you know, we submitted 1115 re-entry waiver, and we are still waiting to hear from the federal government on that one. And that would be wrapping around services post-release for people. How do we leverage data and really focus on equity and changing structural systems with a focus on socially determined health to improve health outcomes for Medicaid recipients? So we are starting to break down the data by race and ethnicity. And certainly also during the redetermination process, we started to look at zip codes that we thought were zip codes that would churn just by virtue of our prior history. And there are communities of color. And we saw that in our data when we looked at procedural terminations, so they didn't submit a form of some kind or didn't get response to a letter that was sent to their home. So then we started listing neighborhoods in those zip codes in partnership with our NCOs, and we did some of those things that you all know with barber shops and things like that. We were also in laundromats and other places in the communities in effort to get people to reapply for their benefits. It's integral to Maryland to meet all payer total cost of care goals through alignment of initiatives and performance metrics, including primary care and quality alignment. So Medicaid has always been at the table for total cost of care by virtue that they pay full rates in the hospitals. So as many of you know, our hospitals are on global budgets. What that means is that every payer pays the same rate in the hospital. Going to pay the same rate. And that's very different than every other state in the United States where commercial pays the highest, then Medicare, then Medicaid. So, and what that means for our Medicaid beneficiaries is they have access to care. We haven't had hospital closures or service line closures the way we have in other states. But under the new model that we will be working towards, which I'll talk about a little bit later, we're now going to be including primary care and quality of life. And that's going to be different. So access to hospital service for Medicaid beneficiaries is really good. Access to primary care for Medicaid beneficiaries is not, especially in certain parts of the state. And then lastly, under the direction of the Behavioral Health Administration, support the development of a coordinated, high quality, equitable system of behavioral health. And that's a lot, but we're trying to do a lot. So the state of Maryland, behavioral health has been carved out of the managed care organizations. So we have, on the somatic side, entities that are incented to manage the care, and the behavioral health side, we have just an entity that pays claims, but no other connections. And at least many of you know about some of the trials and tribulations we've had with Optum, but one of the things that was also lost was the communication between the ASO the NCOs to really manage whole person care, right? And so that's something that we are certainly striving for as transition to our new vendor, Carelon, to make sure that that's happening. Next slide. Okay, there we go. I talked a little bit about equity. So again, care services rooted in equity, data for demographics across systems, across the Medicaid program, and we want to improve language access, health literacy, and culturally competent services. That is much harder. But something that we are working on, trying to figure out the right systems of care. So for instance, I am a physician that is, if you look at the board of physicians, I am licensed, I am boarded, but it doesn't tell you if I'm practicing, not practicing, speak Spanish, don't speak Spanish. And we don't have good systems in our state today to capture on the provider side. The MCOs have some information, but it's incomplete. So if it's there, it's there. But if it's not there, it doesn't mean you don't fill one of these categories. And then even just thinking about language access, many people have access to a language line, but that's not always the best way to provide that service. So a lot of work needs to be done there. Alignment of quality-based metrics with national and state metrics. And this is really important because we have a lot of measures. We have Healthy People 2030. We have SHIP measures. We have hospital measures. We have sinus measures. We have HSCRC quality-based measures. We also have 9 MCOs, all of whom have their own measures. And so certainly we are looking at what is a core measure set for the state of Maryland. CMS has put out guidance, but figuring out what that looks like. But then as we figure that out, how do we start drilling down into race, ethnicity, and how that care for those measures is being? We want to develop a coach and social drivers of health strategy. So how do we do MCO screening of participants and leverage the health information exchange for capturing that information? Don't currently reimburse for Z-scores, which is how providers are starting to do that. But how do we start collecting that information so we can make the case for reimbursement for those services, especially once we provide or connect to that service. And then as I talked about already, there are some discussions on coverage of social drivers and then including in lieu of services, which are provided by the MCO, as part of that oversight. What's not on here, which is something we're already doing, is working with the Department of Human Services. Apparently, under the prior administration, Human Services and the Department of Health didn't have a great relationship, but working very closely with Secretary Lopez and trying to be creative on ways that we can tie SNAP eligibility and some of the benefits that they have that we know are the same Medicaid eligibility requirements that we serve, so we can make it easier for the person trying to access those services. And then lastly, we are moving our MCOs to NCQA Health Equity Accreditation. MCOs to be as attentive to this issue as we are trying to. Slide. So this is what we're referring to as the behavioral health continuum of care. The color denotes acuity. So red is hot, like a thermometer. You have a fever, so urgent, acute. Lighter pink is more about prevention and promotion, and you can see how it goes up and then comes back down. And this was informed when I first got to the health department in January of last year. I knew a lot about behavioral health only as a provider, but I wasn't as well versed in the behavioral health system of care that's provided in the state of Maryland. And so I was trying to educate myself, and I said, okay, let's pull all claims that came through the ASO for 2021 because it was January, February, so we didn't have claims run out for 22. So I said, let's pull everything for 21. And I want to map it, like what is every service from every provider, from every person, and where do we find that care based on where it was from. And so we did that, and we started to see the kinds of things in mental health and in substance use that we were paying for and where we were paying for that service. And then we did the same thing for 22 later in the year. Then I said, okay, let's take the grants and all the grants from SAMHSA, SOAR, OB2A, all the different grants that we have, and let's map those out. So we started to map out the services by county and then created a white space map. And I apologize, I didn't do that. But we now know what services we're providing and where we're providing. And if the box is white, that means we have nothing in that jurisdiction. And so, for instance, as part of this exercise, we learned that if you have an adolescent that has a substance use disorder that needs inpatient treatment, we unfortunately do not have any free for the state of Maryland. Have to go outside the state for services. So what you see here in this behavioral health continuum of care are all the services that we have paid for at least once somewhere in the state, and is inclusive of the services that we. So as we think about this continuum of care, this is how we're trying to build out, well, what should prevention and promotion be? And how do we do more, let's say, on, if you look at universal prevention on ACEs, adverse childhood events, and where is the appropriate place for screening? We get all schools screening, all pediatrician screening, and we incent the delivery system to screen. And then what do you do with that once you find that? So we are systematically trying to build, especially in those areas of the state where we don't have any services, how do we bring the services to the community, assuming there's an N large enough that needs that service. And in some cases, maybe coalescing those services to serve a region, such as what has been done on the Eastern Shore with Shore Health. So a lot of work is being done here, more work to come on here. Really also looking at data, as many of you know, the behavioral health providers are left at a high tech, so we still have a lot of behavioral health providers on paper. We actually just released an RFA to give providers the opportunity to apply for some dollars so that they could get an EMR to start moving on paper. Then by having an EMR, we can have the delivery system. Technology, thinking about telehealth services, which we know was very effective during COVID, but other technology sources. We were looking at apps. I know Baltimore County has an app that they're using for students to self-serve. And we were thinking about exploring that for the state. And what we heard from some people, especially younger, is That's all we actually want to see to say. So we actually put the hold on this since we really understand some adolescents and violence. But those are the things that we're looking at in technology. Talked a little bit about quality of the job. And there are recommended quality measures. Health equity I already mentioned, and workforce initiatives. So like everyone else, you know, there are workforce woes. Maryland has not recovered its workforce post-COVID. The other states have. I don't know where everyone went, what they're doing, but that's something that we are having. The residency slots. Next slide. So some behavioral health innovation and opportunities. So early and periodic screening, diagnostic and treatment benefit. This is not innovation. This is something that providers should be doing, and when we pull the numbers, they're not. So more. This is an opportunity to really screen kids that are struggling. And so we're starting to do some work with managed care organizations to improve our rates in PSCP. Because then we won't have kids and families crashing into the, and I don't know, for those of you who have children, someone once told me you're only as happy as your unhappiest child, right? So if you have a child with behavioral health, the family is really slow, just the child. And so how do we do a better job screening so we can get kids into services sooner? Collaboration with the consortium of coordinated community support. So this is the Community Health Resource Commission and the dollars that they got. So how do we align that under this continuum of care so we're not competing efforts? Under primary behavioral health, one, we just have to reimburse for primary behavioral health that's done by somatic providers. So, you know, family physicians and nutritionists and internists are starting to do a lot of screening, but then they get caught in, well, that should be built to the ASO versus also scaling care. So pilot done during the prior administration where they started testing, embedding social workers and other counselors into the practice and reimbursing that. And it had significant results, and so we're now taking that statewide. Reimbursement for school-based services, working on that right now. We just got technical assistance to help school build, right? So a lot of services are provided, but they don't necessarily have these health centers that help. So lots of opportunity there. Primary care alignment under a head, and I'll talk about that later. Reimbursement for mobile crisis and crisis stabilization. So I'm so happy to say regs are out. Transmittal just went out today on reimbursement. So we have expanded our crisis services in the state and hold out T infrastructure, working on a bed registry via major IT development project. So we can track the beds in the state. And then in coordination with crisis services, if someone needs a bed, we can have 12 beds based on this bed registry. And then treatment and recovery. You see the first two, the community integration services pilot is having wraparound services, stable and new housing. The last one, the access to 15I services, that is a Medicaid waiver that for children with severe emotional disturbance, and it provides a lot of background services. We built a program that has so many barriers. And so, and that's on us. And so that is something we are actively looking at. What we're working with consultants to figure out, mapping out our process and where we can start to, and then understanding to have that step or not, and then eliminating all the steps that people from accessing a service that they need. So we'll be submitting a new proposal to CMS fall of this year. That's something we're working through to so that families can access the service earlier. Next slide. So state health and treatment process, many of you have been here long enough to know and have been through iterations of this, and this is certainly work that Dr. Pollyanna Rahman is leading today. So there's a state health assessment, reviewing quantitative and qualitative data with input, which then leads to a state health improvement plan. What are the gaps and needs for the state health, from the state health assessment, and how do we prioritize areas for improvement? And I actually started this. I did. Exactly. So, and having to address the priorities. So what are the things that we've identified as a priority, and then what do we do? Specifically by interventions or policy, and then how are we going to hold ourselves accountable to success in that process? So a lot of activity happening there. There are some measures. Again, back to all the measures that I talked about, they're preliminary at that point, because as we work on these other models here, we're really trying to tick and tie everything together so that everyone's North Star is the same North Star, right? So we don't have different diabetes measures, we don't have different hypertension measures, asthma, exactly. So that's a goal, and this is a next slide. So this is some exciting work that Dr. Elizabeth Crum is doing as part of this population health value-based payment model, right? You've all seen this model of health before. It's been published many times. Robert Johnson and University of Wisconsin and Population Health Institute have used this, and lots of people use this to describe the impact of the delivery system on person and all these other things. But we sat down one night whiteboarding, and it was late at Preston Street, and we said, what if we could map out all our health services? Let's say we just start with BIPA, which is the Prevention and Health Promotion Administration, and where the local health services are. If we could map out maternal child health, cancer, chronic diseases, and community, what if we just started with those administration? And we said, okay, what are we paying? And let's force the bucket. So are we paying for health behaviors in child's health? Are we paying for care in child's health? Any social and economic factors we're paying for, physical environments, housing, for example. And we're trying to force the money that we're spending in each of the buckets. And we did that for a few programs. Now, it's still preliminary. What would be people's guesses of where we were spending? See, right. And I'm surprised by them. I was like, oh, those programs. Yeah, right. But still, most of them. I know, but still, right? So I thought, right, there's money for clinical care already by the care. So I thought our grants would be a wraparound service around health care, and we aligned our funding with clinical system care. So in some cases, we're doubling certain services, certain things. So we are trying to understand, well, as we think about a population health model and who can pay for what, and how do we maximize in a community, what a community is, we are starting to rethink how we fund things so we can be more intentional about what we fund, so we can create that continuum of care for someone. And so more to come on that, but it's very, very early work. We're also trying to figure out, I know many are familiar with claims-based payment, but there's also a lot of activity that's non-claims, that's not captured in the claims system. And so we're trying to put almost a per member per month on what some of these programs cost based on how all those things. And I'll give you a very, very quick example. There were some additional dollars that came to the state related to lead. And so we have historically taken what I call a peanut butter approach, where everybody gets a little bit of money, but not enough to really move the needle. So we have for lead because these were additional funds, and some of the counties didn't get dollars for lead. But what it meant was some counties got money for lead, and the per beneficiary per year was about $20,000. So one county got money, and it was and got $20,000, $20,000 for that child. But a place like Baltimore City, and you have it ended up being only a couple of because the ed was so large in this effort to try and spread the funding. So that is an example of, does everybody need a little bit of heavy concentrate dollars? And then for those jurisdictions, that the jurisdiction that did have two cases, how do you absorb those services and other work that you're doing, or lean on another jurisdiction that has funds and expertise to help? So a lot of activity is going to be happening here. So more to share some very, very early that's happening in the States. Next slide. And this is a regional roadmap, you know, of the ideal state. So in the community, we have health promotion and education, we have resources for housing and transportation, address food insecurity, family and social supports, and community safety, and healthcare delivery, provider training, and that could be anything from, you know, the latest medications you should be using, implicit bias training, clinical supports, you know, those community health workers, quality improvements, and certainly activities to dismantle institutional racism and implicit bias. We know we have policies that perpetuate racist activities, and so how do we look at those policies to make sure we're so that doesn't happen? Upstream measures, changes in knowledge, attitude, and behaviors, and certainly risk factor reduction, disease and clinical measures, access, connection to care and services, clinical care metrics. Many of you know, insurance card doesn't mean you know how to access your health care. But once you access your health care, is that health care? Some of our overall well-being, reduce mortality, especially the discrepancies we see in mortality, symptom level, decreased morbidity, decreased disability. Now we have no health outcomes disparities based on race, race. No Pollyanna-ish for those of you who know Pollyanna, but that's the issue. Next slide. So how do I tie this all together? So this is a model that CMMI released earlier this year, states advancing all payer health equity approaches into health. And it is basically the total cost of care model, statewide accountability targets for Medicare and all payer cost growth, Medicare and all payer primary care investments, equity and population outcomes, state agreements with CMS. And if you look at the bottom, equity integrated cost model, behavioral health, all payer Medicaid alignment, and accelerating existing state innovations. And in the middle, you'll see it's Maryland's model. It's the all payer hospital global project, it's cooperative agreement funding. And even though they're referring to primary care act and Medicare value-based payment arrangement, Chad purposes, so phenomenal job practices. But now as we rethink, we know access to care in the hospital setting, but not necessarily in primary care Medicaid beneficiaries. And so they will be included in the next negotiation of the model. Behavioral health needs to be integrated in the next negotiation. We need to have a statewide health equity plan. And all of this is basically a value-based population health model. So how do we start sticking in time all the other slides that I mentioned as we think about roles of responsibility in a community for health? But this is the model, and this is the change. Next slide. And this is just how it builds on the total cost of care. So spending or population health. Is that my time? No. And we certainly put our advanced health equity by reducing disparities in health. And then the last slide. So course knows I love quotes. And so, I lead with a quote, I end with a quote, and certainly the work that we're thinking of, that you all are doing as part of our mission is, how does what you do, sort of thinking about doing vice versa. So, to me, this teamwork is the ability to put together toward a common vision, the ability to direct individual goals, organizational objectives. It's the fuel that allows common. So behavioral health, and the behavioral health, so, are very integrating in taking substitute treatment from the state of Maryland. It's been family on that, so, city, working successful and having consistent outpatient treatment therapy this year, the general center, the bill has failed 22 years, and that don't fit in line. What that means is, it's, mandating that you take medicine, but the opportunity is in lieu of homelessness, jail, or quite frankly, death. Building capacity for adults, and making sure that people of color have the same access to services that other people don't have, that other people have access to. So that's one. The work that we're doing in Medicaid, that's two, and that's writ large, thinking of enrolled in Medicaid, thinking about the 1115 waiver, certainly exploring social drivers of health. And I'm not necessarily convinced that Medicaid should be the one paying for social drivers of health, but how do we leverage the entities that are paying for social drivers of health and bring them in to make the case? There are certainly lessons learned in California and other states in the West Coast that are following that closely.
So is this like revising incentives for MCO?
Potentially, it's more like realigning the MCOs to one North Star as opposed to their North Stars. That's one of the things, but even their services, it's all over the place. They use those as an opportunity to say, pick the MCO or another MCO, but all those things may not be important to the people that need certain services. So if food is important, how would we leverage the MCO to provide food as in lieu of service for people that need that as an example?
That should be an area that's helpful. Our recommendations around the chief public health metrics that we should track going forward and sort of find them your vision for what the MCO should that certain amount.
I think when we figure out what this core measure set is, which will be a very public process because everyone has an opinion on what we should be measuring. I think once we have that, then that might be the thing that it means, assuming it's redundant. Maternal child health, big focus. We have a new women's health strategy, very focused on Black maternal morbidity and mortality, especially the postpartum visit. We know that
4% of those deaths are
absolutely preventable.
So
So
if I
if I
could
could get it to zero, then I would get it to zero, but certainly
4% is not acceptable.
so
So
that's
that's
just my level.
did that answer your?
Yeah.
Sure.
Oh, it's on.
Thanks. Mhm. Especially for questions.
All right, so I'm gonna, I got some.
First of all, thank you. Thank you so much for being here. And I do want to say, so, you know, to the extent that you're saying that one of your big stars is determination, I did attest to that. I think I shared with you, you've been doing a lot of work around determination. I shared with you a couple of the challenges that you were having. You're exactly right. The populations that are most concerning do not want the language lines, and we're needing to connect these. So thank you so much. Kind of want to start up at the top. I do a lot of work with CMS, which is a quality conference to help. And I'm also on the consensus building committee at CMS around the health measures.
Mhm.
And so to that extent, back to the MCOs being able to use Medicaid, those levers is so very critical, you know, and important. I want to talk, you mentioned about the provider network. And so my whole focus is going to be on that. That's where I'm at. I would ask you to please attention the provider network adequacy. And you're right, many of the providers, we don't know if they speak Spanish. That's important because that's trust. And we know minority populations, it's about trust. When I think about maternal health, so we're also working on SUD, you know, and it's almost a death sentence for a minority woman to have a baby. It's just unvaluable. Well, what are some of those reasons why maybe they're not going to not have enough OB-GYN? I was just recently, just this week, I'm calling the doctor's office. The doctor has a practice of 15 years. But, I mean, and so the number is attributed to a doctor that's not even.
Wow.
But what I'm just kind of saying is, how do we hold those that you're saying, look, is your provider network adequate? No, they need to know, are they still there? And just building in levers, because you're talking about primary care access. We had very well aware of it with Silver Line. And it's not just the hospitals, it's practice. And levers can trust that those doctors truly are part of the network. So I'm asking for some, and I'm happy to give you some ideas around that, but that provider network piece is really crucial. So let me pause for a minute and let somebody else know, because I got some more. Anybody else out there about?
Well, we don't have any systems. So other states have a statewide workforce database that captures this information, and all our boards have their own systems. And some of our boards are still on paper. You have to apply on paper and you have to fax. I mean, and last General Assembly, many of you know, there were some issues at the Board of Nursing, and the General Assembly said, yet you got to work with the Department of Health, and you're not going to be independent for a little bit of time just because you need their help to clean things up. And they were long lines outside, people trying to get their nursing licenses. We were losing nurses to other states because they couldn't get their nursing license, and it just wasn't nurses, but nursing assistants. And we went there even before the bill was signed just to see what was happening. They had two systems that don't even talk. One on the front that takes in the information, then they manually move the information and put it into another system on the back end. And so that was part of the problem. So we have a major IT development project that we're working on a new nursing platform, and all the things that I'm talking about are going to be in this new nursing platform. And our hope is that the nursing platform can then be retooled for physicians and for audiology and for, all the other workforce. We recently met with Wisconsin, who used their ARPA dollars to develop a licensing platform for 70 clinical specialties and non-clinical specialties. And it was pretty pretty impressive. And they did it in 2 years. I don't know how they did it in 2 years because procurement takes longer than that in Maryland, but they did it in 2 years. And they're willing to share with us what they did and how they did it and how fast. So we have a follow-up because we got to see the generic platform. We didn't get to see the nursing platform. And nurses license more than half the clinicians. We have about 420,000 clinicians in the state of Maryland, and nurses and nursing assistants are probably about 250,000 of those. So if we could figure it out for them, we think we can figure it out for others. So more to come on the information about the clinical people we have. As far as network adequacy, it is a requirement to be an MCO, especially to be an MCO in the jurisdictions that they're in, that they meet network adequacy. I think it doesn't always feel adequate to people when they're trying to access services. And some of that is also how many Medicaid beneficiaries they will take as they try and diversify their revenue stream into the practice. So a lot of moving pieces, but something that we're actively working on.
It's kind of made me hold more accountable. When they have it show, January, but how useful.
Well, I will say provider directories are a national problem. They're terrible.
They are.
Okay.
They are. And it's like more complicated. Try to put it
Mhm, yeah.
Another question, doulas. I know this is down lane. We gotta figure out a reimbursement for doulas. Figure out an evidence-based strategy, and certainly I think could help with the, with the kernel piece. You mentioned primary care and quality alignment. Can you talk a little bit more about, what you're thinking, kind of what CMS and
So,
particularly
I mean, who are the docs in the room? When you practice, did you know the payers? No, right? You were just providing great care. And then somebody told you, no, that patient can't have that thing because that's maybe Aetna and you have Care First, and like whether you wanted a care manager or certain. So at least on the quality side, we are trying to align. So it's agnostic of payer. Your job is just to provide great quality care. You don't have to figure out whether or not that client or that patient should get that service by virtue of the fact of which insurance company they're tied to.
Yeah, no question. I mean, that is a problem, especially when you're talking about the need-based, providers. So, which insurance do you have? I think my last thing that I was just really going to say is around FDOH, to the extent that, I know for a long time CMS said, we pay for healthcare, we pay for social care, but it's so closely aligned, we all know the new services, just continuing to think about innovation in that area. And last, thank you so much. You are keeping equity at the top of mind with the plans. Continue with that's your biggest lever. That's the biggest line item. That's huge. And so to the extent that you continue to do that, I think really can move forward in achieving, your what do you call it? Your pretty audacious, your audacious goal. Thank you so much.
Thank you.
I'm kind of relating to SDOH and your prioritization of sort of Medicaid population, both maternal child alcohol, often that's covered under Medicaid. And your sort of vision for the future. One of the challenges from specifically Medicaid care leaders and providers, frankly, is sort of the discontinuity that often occurs, where a patient sort of rotates from one is getting out of Medicaid or into one plan or another. One of the things that we have here is that we don't have in other states is the exchange, the built in. The early days of working on that, we tried to use the matching capability. What Chris does really, really well is integrate data across silos, right? Using don't always get it perfect, but probabilistically matching identities. So John Smith is the same as John. And one of the early conversations we had was with like the SNAP and sort of the non-healthcare, but super relevant to healthcare outcome data silos in the state. And there's a lot of there's actually political silos in the organizations that prevent sort of collaboration on that. And so I wonder, you mentioned you're having conversations with, I think, the Secretary of,
Lopez, yeah, Human Services.
Human Services. And so maybe some conversation around that. And then secondly, given the infrastructure we have here that is better than anything in the country, is there any possibility of sort of revamping how we incent, like how we incent the MCOs in the interest of sort of building towards better public health across populations, as opposed to just maybe measuring, the 1 year, like, is nobody wants to invest in a person. They're only responsible for the outcomes of that person for a short time.
So that's something that we're working on, right? Because, core public health services takes time, right? So you need the expectation that you'd have in-year savings or some return on investment in a year is not always realistic. And so that's certainly something that we are working on as part of the next version under AHEAD. How do we create the window for 2 to 3 year blocks to give time for those population health investments to take hold and demonstrate? And for those, it's not so much cost savings, but cost avoidance, right? You avoided the ED visit, you avoided the inpatient visit, and then how do you capture that? So that's definitely on the radar.
So, great and very exciting, the job that you have this month. So I just really commend you for your energy. Getting up in the morning every day, doing a great job. So let's talk a minute about, you got this universe of public health around every county and doing a whole lot of things. And this exploding universe of population health bureaucracies embedded in hospital systems, right? And with the AHEAD model coming, really visionary ideas about going upstream, but I'm seeing two completely siloed entities doing very similar things, but without having any kind of meaningful deconfliction or way forward. So I don't know if you've thought about what that might mean or how to reconcile all of that.
So I agree. And I don't necessarily, can I say it in the room? Like everything's been captured. I think it's recorded. I don't think the hospitals do a good job of doing population health. They're not population health experts, and we should leave population health to the population health experts, which are our local public health departments. And so we're working on creative ways to make that happen.
So if there's anything this commission could do to advance those creative ways, we're all in. I think we all see that there's an opportunity for real collaboration, but not duplication. And I think that is really the goal. So if we can work in whatever way.
This is maybe not the forum to have an honest conversation, but the hospitals are the pigs of the trough. I mean, they have so much more money than everybody.
Just remember, I did not say that.
But like, I mean, they could be good at it. They could be good at public health if they had.
Oh, sorry.
But like, they could be good at managing towards like maternal and child health. I was kind of like, yes, because you could really move the needle on that if the hospital if they wanted to. If they had the incentive to do it, that was meaningful relative to their.
Well, and that's something that we will be building into the next version of the model. There are already quality incentives that are tied to the hospital's performance, but there's not a lot of money to it. So it doesn't have enough teeth. But then under the AHEAD model, every hospital will have to have a health equity plan. And there's no way to do the equity plan without a population health focus of doing that plan. And that health equity plan needs to feed into the larger state health equity plan. So there are things that we need to do under the AHEAD model, which I want to be clear, we have not learned yet whether we are in. It's imminent, we've been told. So in the next couple of weeks, I know, how could we not, right? But
Yeah.
No. New York applied, Hawaii applied, and Vermont. Vermont applied, and there might have been another, I can't remember. Those are the three that I know, but, yeah,
You
so,
have so much power, like the HSC, like the rate, like you could do things that no other state could even dream of doing. And I hope that this is such a unique moment in time
mhm.
where all of these things are happening at the same time, that we, that we're aggressive. And so I just, like, we have a role to write paper, like that's the only thing we do, right? That's our,
But it's an influential paper.
well, maybe, it
Yeah.
depends on what it says. If it
Yeah.
says nothing.
Well,
Then
make
they
sure
don't
it
need it.
doesn't, make sure it says something.
Yeah, well,
Yeah. Okay.
And then Mina did the
Yeah.
same.
And what
Can I
Fran
answer the
said,
question?
I have the benefit of working very closely with a lot of the hospitals in Maryland and with the Maryland Hospital Association, and being on this amazing commission, and being part of the Diabetes Action Committee and a lot of other things. And so I literally have my feet, like one foot in one neighborhood and one foot in the other. And so I do want to say, to kind of counteract, sorry, Chris, but like there's not a hospital that I know of in Maryland that is not actively trying to address
Mhm.
all of these issues, particularly the maternal health disparities. What I have noticed is that, so going back to what Fran said, there's so many siloed efforts, even within the hospital systems. This hospital has this initiative, but this hospital has this initiative. There's not a lot of structure for information sharing of best practices. And then also between public health and hospital, they don't know what you all are doing. You all don't know what they're doing. And I find myself sometimes in meetings literally kind of being like, oh, well, I heard in this MDH meeting that this is going on. They're like, really? So I hope that as we move forward, there's an infrastructure that really allows for more collaboration, because there's a lot of good work, but it's being done in silos and no one knows about it. There's a lot of duplication of efforts. There's a lot of redundancy. And I think we have the ability to do amazing. We're already a model for the country, but we could do even so much better if there were just the infrastructure to really allow this sharing of information.
Years ago, under the SHIP framework, there were local health improvement coalitions that were led by the local health departments and included the hospital, your community-based organizations. I think some counties have been very successful in keeping their local health improvement coalitions going and are the entity that works with the hospitals for their community health needs assessment and things like that. But under the work now that's happening to, refresh SHIP, that's part of it. How do we support the local health improvement coalitions, or the ones that have been successful in maintaining their local health improvement coalitions? Like, or I think yours is really rising. You have everyone at that table. So like learning from the counties and the jurisdictions that were very successful in keeping their local health improvement coalitions. And sometimes it is the leader who has been there and driving it, and the leader goes, and then the coalition kind of goes. But how do we structure that, or set the floor, for lack of a better description, so everybody is doing something in their jurisdiction? So that's part of the work that Dr. Kalyana Raman is doing with the local health officers. So more to come on that. But we have tools that have worked in the past that have kind of fizzled in some jurisdictions. So they just need to be recharged. Amina, I know you had a question. Yeah.
Mhm.
Yeah, my question, I really appreciate everything you shared, and especially highlights of primary care throughout everything that's. So I want to circle back to that, because I think that is so foundational to all the disparities that we are seeing. And yes, we're here as a Commission on Public Health, and we are looking at the public health infrastructure at the governmental levels. But such a key part of how we deliver our public health system locally has to do with our partnerships with primary care, and also access to primary care in the local. We all know, we all agree, that is so incredibly foundationally important to those long-term health indicators and outcomes. So there were a couple things that popped up that I just wanted to query. One comment you were making about the investment in clinical care, I think it was in the model of health side and so forth, but re-looking at that, because of course, theoretically, there will be services available, and we don't want public health to be duplicating what's already there. But
what we've found, at least in my community, is that the healthcare service sector is not meeting the demand of the community, either from the public, either from the primary care perspective, or even from all the various specialists and so forth. And maybe that's an experience of all jurisdictions, but I've heard about it so much more for the 18 counties around the state that aren't in Central Maryland. And that makes me wonder that if we redirect that's beautiful. We need to be looking more upstream and so forth. But if we do that without the precedent shoring up of our primary care infrastructure, which will take years, I'm really concerned about significant gaps in basic preventive healthcare services that we will start to see increase, particularly in our 18 jurisdictions.
So I want to be clear that I take my Hippocratic oath of do no harm very seriously. So we're not going to break anything. But there is opportunity to improve what's there. And as far as the primary care investment, I think I saw Ben on the MHCC has been leading the work of the primary care investment work group. And, there are thought leaders at Millbank and Commonwealth that say that primary care investment should be about 8 to 10 cents on the dollar. And right now, depending on the payer, you only get 4 to 6 cents on the dollar. And I don't think anyone's getting 6 cents. Maybe those, we are. And then to your point about the pipeline, we only have 2 major medical schools in the state, and we don't have enough primary care residency slots. So that is impacting the pipeline on the physician side. And then even on the nurse practitioner side, nurse practitioners that might be doing primary care are getting lured into specialty care because they can make so much more money. So other states are actively addressing their primary care shortages. We have a lot of work to do. When you look statewide, it doesn't look like we have a shortage if you include all clinicians, but they're not distributed where they need to be distributed. So a lot of work has to happen there on that. I would say we are in the very early stages because the residency slots, that money goes through HSCRC and the rates. And so we're trying to understand, even from a Medicaid perspective, what GME we are paying for. And of those GME slots that we do pay for, how do they support Medicaid beneficiaries?
And in case in point, so Robert Graham Center for Policy has some great research on this. Looking at the maldistribution of primary care and the problems that we have with the primary care pipeline. If you could just go to some of the roots of what we do with GME dollars, where are our revenue?
I know, I saw their 2024 scorecard. I know it by heart.
Right. And if you think of it, how many schools of medicine there's to have a department of family medicine? Yeah. Family medicine, which will see all ages of patients, and the core primary care specialty is the one that, if you look at the research, those residents tend to stay in the communities they treat. And
I'm a New Yorker, came to do a family medicine residency in Maryland, and I stayed.
Right. But how many of those family medicine residencies are located?
Yes, I agree.
We have Jared's just done a great job by launching one. And I thought there was a city working on the East Shore, but that's relatively recently. Sorry.
Yeah. The one thing that I would point out is that each family medicine doc controls about $10 million in medical spend every year. So the incentives are something broke.
Okay. Yes. Okay. Thank you.
Out of the primary care doc, if they actually care about care and quality, because each of these docs $10 million a year of medical spend effectively, and is effectively sort of directing traffic. But they're going to spend 7 minutes with a patient. Get the next one if they want to make more money.
Yeah. I have a question. Yeah, about and then Dr. Rossman. It's about we've been talking about the pipeline, and you mentioned during your presentation that nurses and nursing assistants, they doubled the number of clinicians in the state. So do you believe that formalizing interagency relationships, right, through the establishment of a state-run board of public health, right, would help with some of the issues that we're facing in the workforce, especially if there are opportunities for having a system run by to track, monitor the people that are coming in, right? To also assist with training. Some states are already looking at this, but do you believe that it is worth the while? And do you think that it might further impede the already short workforce, especially in a time like this?
So I don't know how it would impede the workforce. I
Okay.
think knowing what workforce we do have that's actually providing care and knowing where they provide that care would help us be more intentional in how we think about loan repayment or, some schools, NYU, for instance, medical school is free, but you got to stay in the state. Could we create some incentives to create the workforce? I know there's a fiscal note with some of those things, but I think it would allow us to really just understand where that workforce is. To Mina's point, like it might exist in the city, but it doesn't exist in St. Mary's County. And so then how do we say, okay, you can get, I don't know, maybe free
Yeah.
tuition, but these are your choices in the state to get free tuition, as example.
I think, yeah.
And NHSC, certainly National Health Service Corps, I got loan repayment and that's how I worked at Penn and North and Druid and Hill and Caroline Street. It
Yeah.
was because those were health professional shortage areas and that's where I worked to help pay
Yeah.
off some of my student loans. But I think we really need to understand the lay of the land and I don't
Yeah.
think we do. And we rely on like papers from the Graham Center and the 2024 scorecard, but they don't get granular enough to really be as specific as possible about
Yeah.
where the workforce needs to be.
Yeah. Mm-hmm. Yeah.
That's being distributed across Maryland.
Right.
Major aspect of that is the number and location of
Yeah.
primary care residents. In
Yeah.
particular, residents at campus, they immediately after this.
Yeah.
versus going on the bus.
I think those are great points. It's also good to know that if this eventually becomes established, it would be good to capture other people from educational, like nurses that are doing community public health nursing, right? Not necessarily MPH or DRPH, but there are other tracks to public health. And maybe again, having a license, that people can do, right? Would put them on that portal and then we can better track. Thank you. Dr. Rossman, and then, yeah. All right.
I'll take credit for this. So my daughter is graduating as she's currently in Rochester. She's coming back home. We'll be adding to the.
She's done with the cold.
Pardon?
She's done with the cold.
She's done with the cold, yes. And just for a moment, I do think that primary care is, we're in Howard. We have too many physicians. If you look at the roles, but they work for the FDA, et cetera, et cetera. And the other thing that is very real is concierge. I can't get an appointment with my primary care that's meaningful. And like, I know people. So there's a real cliff in Maryland, and for at least I can talk about my daughter's, her husband's friends. Maryland is not attractive in terms of salaries for primary care docs. You can go to Virginia and you're going to get at least 50% to 100% more. So they're coming home because she wants to be close to me. So thank you very much.
Thank you. We'll take one last question. I'm sorry.
The real question I wanted to go back to public health, Laura. So you mentioned local public health and maybe the SMEs for population health, if you will. And I don't know if you're able to elaborate on that. I do also agree that at least at this point, I don't think hospitals who are really focused on acute care, and man, they're struggling too in Maryland. But what do you see the role of the local health in terms of this population health goals and whatever North Star for us 24 jurisdictions to obviously continue to work within our communities, which are different, but there are obviously commonalities.
So, that, healthcare is local, right? And who are your healthcare players at the local level? It's your local health department, it's your hospital if you have one, which is often your anchor institution for healthcare. And then it's your providers and your local behavioral health authorities. But from a population health perspective, I think of the local health department as having the SMEs to drive that work. And then some of the health departments have the behavioral health piece integrated in, but have the connections with the hospital for a variety of reasons, the reportable diseases, for one as an example, or because you're doing the prenatal risk assessment form. So there's a lot of already ties to the health department that the delivery system has. From a community perspective, you have a lot of ties to the community because you provide direct services, you provide the education. Oftentimes you are the frontline staff in whatever event or activity that's happening in your jurisdiction. But how do we then take the work that you're doing to be the convener facilitator, to really be the person saying, grouping everyone together and said, we as a community have decided that these 5 things are really, really, really important to us. And they may not be the 5 things in Howard County as they are in St. Mary's, but when they are, let's agree that the things that drive the outcome for that thing are the same, or at least the way we measure it is the same. But that's the way I think about local. And that's what I think I do at the state, right? I'm working with the Maryland Hospital Association. I'm working with the Health Services Cost Review Commission. I'm saying, no, look over here, because this is really, really important. And when I mean look over here, it's public health, it's population health, it's behavioral health. And yes, you are focused on acute care, but you wouldn't have to focus as much on acute care if we could solve this problem up here. And so I think that's what our respective roles as leaders in the public health, population health spaces is to be the convener and facilitator and educator on what that looks like in your jurisdiction.
Thank you. We'll take one last question from Commissioner Budnow.
On silos, I think how I ended up on this commission. But to Chris's point earlier about, we understand that there is a political aspect to the policy, but healthcare needs to be agnostic. And that, to your point, Secretary Guerrero Scott, the early investment on population health has a huge return on that investment, but you don't always see it in the out years. So how can we establish guardrails to make sure that the work continues and that we establish roots deep enough to weather a change in administration, a change in a leadership, and so we can still see the positive results in real time, but also make sure that we're not beholden to seeing results in 2 years or 4 years or 6 years, because we know that the long-term population outcomes are going to be exponentially important, and we need to be somewhat agnostic to the politics of it. So how is we as a commission, can we help grow those roots to make sure that work continues?
I mean, I think you all have expertise that could weigh in on what those roots are. I mean, I could probably think of you, and you're a delegate Bagnell, so there's one obvious tool in the toolbox right there. But I think is what are those tools in the toolbox, and not everyone needs a hammer and not everyone needs a screwdriver, but to have a suite of what that looks like, so locally people can be successful. And if you're successful locally, you're successful at the state level. And then I just lost my train of thought, but yeah, that's what I would say. It's,
we're gonna squeeze in one last one from Boris. I know it's how we don't want to stop. I mean, wish we could have you all all day. I'm sure people in the room and those online would really appreciate. We want to take as much as we can from you. We really appreciate it. Let's go take from Mina and then from Boris there.
So quick comment on this conversation, but I think really, really important to highlight the role of FQHCs and community health centers in delivering and shoring up our primary care infrastructure. I know we don't have the adequate pipeline. We definitely need to work on that. But CHCs, FQHCs, they play a tremendous role in addressing so many of these gaps in primary care. I feel like we could have a much more robust strategy to support the establishment and maintenance and so forth of the CHCs in our state, and as well as the distribution. And I'll say our county for many, many, many years has had a health professional shortage area designation for primary care and mental health. And the southern part of the county in particular has been completely devoid of any primary care for many years. We have not had an FQHC in our community. The FQ, I mean, so we've had somewhat of a presence, but that presence of the FQHC has been in the most lucrative area of our county because they also have needs because there's just a gap in primary care. So we really need to do more, I think, as a state to incentivize the buildup and the establishment of CHCs and QHCs in all of our health professional shortage areas in the state.
Well, I would tell you under the AHEAD model, we do have dollars put aside for primary care investment infrastructure for net new providers in health professional shortage areas. And it is supporting practices in the first couple of years while they get their revenue going and can then be self-sustaining. So that RFA is going to be released imminently, but it is intended to bring primary care providers, FQHCs or other primary care providers to health professional shortage areas. It's not to supplant a practice from one place to another, from the hospital to an FQHC. It's got to be net new and allows for people that don't have access to primary care or have a primary care provider on paper only, but you can't get in the door. So that will be coming out this summer.
Thank you.
It's not going to address all the HIPSs though. There's not enough money for that, but it is focused. Yeah, exactly.
All right, one last question from
So it's not a
Boris.
question, it's
Oh,
more
okay.
of a conclusion.
Conclusion.
Since I have the
Love it.
honor of introducing you, I also will have the honor to close this session. First of all, just by the exuberant questioning, this shows that this group is really interested in having a great relationship with you. We've only been at this for 6 months. There's a long road still ahead of us. And yet, getting back to what Chris had mentioned, is at the end of all this, our goal is to come up with real and robust and good recommendations. This means at the end that ultimately we need to be working with you at the state level, with the locals, right, with the partners that involve all the aspects of public health within our beloved state. So we have to go in, again, exuberant, optimistic. At the end, the commission hands it over to leadership and to the legislative branch, which needs to make decisions. That's not necessarily going to be our job as a commission. But what we guarantee you is the level of enthusiasm you saw here will continue. And it's not just the 16 commissioners, it's the 100+ people involved in our working groups, right? This has become an all hands on deck volunteer approach. And we thank you for your time today. We're going to do a photo op, if you don't mind, just to document this in our history. But also at the same time, if you can stay on longer, it's up to you. We have a robust rest of the
I have a
agenda.
3 o'clock that I missed, but
But anyhow, I would like again to thank you on behalf of the commission for your attendance. And this won't be the first or the last time that we'd love to have you here with us. And as we briefed you on last week, we'll continue briefings from a co-chair's perspective as well. It's great having members of your team as well on this commission, and they play a key role. We know they represent you well, but also having you here intertwined with us intermittently is going to be really good. It raises our spirits, it raises our morale as well. So thank you so much.
Thank you. On that note, we will take 10 minutes break. It's going to be about 3:43. All right. Let's, for those online, get up, warm up. Yes. And we'll put the mic on mute now, but please stay on. We'll be back. We have another wonderful presenter. So we have a packed agenda today. All right. Thank you.
Can you hear me?
Yes, we can.
Okay. To do a sound,
Hi, Ben.
I was really worried. The sound was horrible for a while.
Well, it still is in the room, but on this computer, you should be able to hear us. So what we might do is to move the computer around as needed for questions. But yeah. And we still have IT still trying to work it out.
Can people hear me?
Yes, we can hear you right here in the room. And you can hear us clearly too, right?
Yes, yes.
All right.
Can hear you. Can you hear you very well on that computer?
On this computer, yes, thank you. All right. We'll try and see if we can move this one around. So, Ben, if you don't mind, we just have a few updates. We want to try to follow the agenda so that we can try to cut on time. We just have a few minutes. We're on item 5 for those that are looking at the agenda. I would, as we move along, I will have Shane please give us updates on the commission. Thank you. And you can see that on the slide. Thank you.
Yep. So
yes.
I'm going to truncate this just a little bit and start by saying most of what I'm covering I have shared earlier today by email with the commissioners and the work group co-chairs and coordinators so that this information could be reviewed ahead of time, but also reflected on later on. So what I really want to do is just hit on a couple highlights and make sure that we still have ample time for Ben's presentation as well as the work group updates. So next slide. We updated the timeline that we previewed last meeting to reflect the changes from the statute, as well as making sure that it brought into conversation and documented the milestones and deliverables from our assessment partners. So that timeline now reflects our engagement with University of Maryland, as well as Morgan State University and some of the different assessment-related deadlines, as well as building in some checkpoints for our final interim report, which is due later this year, and giving a little more clarity on what the work groups should be looking at. So as we have identified different speakers and items of interest, that has been included on that and will continue to be updated on a monthly basis. So really most of these documents that we're talking about are kind of living documents and not necessarily something that should be considered as gospel without making sure that it's the most recent version. So the next slide. This is just a quick screen grab of that updated timeline. It's through the month of September and reflects kind of our summer cadence of activities here. The main takeaways are that we do have 2 speakers planned for next month. The first that's confirmed is Marcus Fluckner from the Community Health Resources Commission, and we are currently working on getting the Health Services Cost Review Commission finalized, but we believe that we're pretty close on that. It also highlights our upcoming site visits and listening sessions in Howard and Montgomery counties. We are now shifting our activities and focus away from just the assessment portion of this conversation to looking more at how do we actually start to make outreach and more handoffs, as well as getting into some of the content and what our work groups have been finding. And so you'll start to see in October and later where we go into these deep dives where our work groups are going to start sharing emerging themes and what they have discovered, which may eventually translate into domains of recommendations, but are not necessarily recommendations themselves. So this is, again, just the snapshot that I promised we'd go over at every meeting. Next slide. One of the other documents that we put together is more detail around what that timeline kind of highlights and gets at. And so this project activity detail sheet mirrors what the previous timeline, the format looked like, with a little bit more specificity on certain things. We wanted to call out specifically what work groups should be focused on and what the broader commission should be looking at. while also highlighting some key dates. So the two documents should relate to one another, but they are really for different audiences. This one's really intended to be more of a guidance document for our work group co-chairs and coordinators to understand kind of where they should be in terms of timelines and focusing on different activities. And so it's not finalized in the sense that, there's some dates proposed in there in terms of when drafts are due for the interim report and the final recommendations that were put out because they provide ample time for review and so forth. So what I'd really appreciate from the work groups and commissioners is for you guys to take a look at that and let us know if those dates don't work for you or we maybe miscalculated in some way. So there certainly is opportunity for feedback. Additionally, if the content seems conflicting, would like to know that as well so that we can, get you the answers that you need on that. Next slide. The final new thing that I want to introduce today is really a follow-up on a number of conversations that we've had as I've chatted with different work group co-chairs, the coordinators, and even just in conversation with some of the commissioners themselves who are participating in work groups. There was an ask to have more definitive guidance on what the work group should be doing and where are things going, how can we make sure that we're on track. So the project activity detail was part of the intention of that, but we also wanted to provide something that was a little higher level and focused more on kind of a framework approach. And so recognizing that the statute identified some things that and was pretty prescriptive on, we wanted to make sure we were tracking those within the work groups. We also wanted to provide a place where we could document conversations as they've occurred in the sense of, hey, we need to make sure that this work group is studying this particular thing based on dialogue that's happening. So as those things occur, getting those documented and written down. And then just kind of level setting on, best practices in terms of looking nationally at different subject matter experts and bringing folks into work groups to chat and share perspective beyond just what's happening in Maryland. While it is a fantastic public health system here and there's a lot to be proud of, there's certainly great things happening outside of Maryland that could be adapted to fit the needs here, especially around health equity and some of what we heard from with Secretary Herrera-Scott's presentation. So on the next slide, we show what that charter looks like. And again, I apologize, it's an eye chart, but this is an email for you folks as well. And it really kind of just delineates the specific items for each work group to consider. And that, again, that was shared with the work group co-chairs and coordinators so that they could really start to unpack some of that. It will certainly be evolving and making sure that folks understand and agree with kind of where these asks are, but we felt that this was a good starting point. So that first kind of teal column or row there reflects the work group specific activities. So these are going to be the things where somebody has said, hey, we need to make sure this work group is looking at the talent pipeline and not just retention metrics. Or, we've heard a number of times from site visits that centralized systems have been challenging for different users. And so how does that get tracked within the data and IT work group? The blue bar or blue rows are the basic activities that every work group should be kind of on a monthly cadence, making sure they're addressing. So that is the research analysis piece, bringing speakers in, engaging your membership to make sure that they stay, immersed and, feel like they're contributing to the project and so forth. And then just below that a little bit, which is kind of cut off here because of the screen size, is a darker box that identifies those statutory requirements that we must consider in all contexts, such as infant maternal mortality, procurement and contractor oversight, health equity, substance use related deaths, as well as other public health emergencies and the COVID-19 pandemic response. So not that those are necessarily charged to any one work group, but they really should be tacked onto your lenses of analysis as you're reflecting on these different pieces. Next slide. Because it does reference it several times in the both the statute as well as the charter document, we also included a link to the FAB, Foundational Public Health Services, and a little more information there. So I won't belabor that. Many are familiar with it, but if you're not, that resource was included with the charter. Next slide. Again, I won't belabor this too much, except to say that in July, we will have a formal introduction with our academic partners to just kind of begin the kickoff process with that assessment. And then in August, we do plan to have a more robust presentation from them, kind of going over the protocol and how we plan to go about that, as well as where work groups can be part of that process and integrate in with the work. What's going to be really critical is making sure that we have warm handoffs, that we're leveraging connections to make sure that people participate in the assessments.
Just for like by way of this timeline, give us like the quality metrics process that Laura mentioned. Seems like one of the any sense of that one. And same thing. We kind of want to make sure that what we say lines up with what those things are saying.
So the head will find out, I think the head will find out a little bit more. I think she was saying there's 4 weeks. I'm sorry. Yeah, the first iteration, right? But she was referencing an update. And I definitely think we already have invites out to these commission meetings. I know separately, a couple of our work groups have also directly approached me to PRC on specific topics. So I think we'll definitely, that's a key point that you're making.
That was the second one is that I've heard about this other process happening at the commission, maybe not, but that there's an effort to try to like at least I always thought it was focused on quality metrics, but like quality metrics and public health metrics and sort of what we're measuring and on it, there's a lot that like there should be alignment there. So like
clinical quality metrics.
It's like it's how the MCOs are measured,
Right.
which is like super relevant.
Yeah.
The secretary was talking about that.
Yeah.
So there's a process that's collecting input, it's looking at all, like each of the MCOs has their own thing, CMS has their stuff. But that's a process, we should probably track it and figure out how to.
And then money's are directly related.
Yeah.
In a huge way. The
Yeah.
incentives and disincentives.
But like, it should be lined up
Yeah.
with what we want.
It should, yeah,
Public health.
yes. As well as I'm thinking equity, right? So when you look at like breast cancer screening, well child measures, and even the PPC, the timeliness measures around maternal health. Talking about, I mean, maternal health is a huge, so I think there's no question there should be an alignment between equity, primary care, we gotta get the kids in EPSDT, you heard her mention that, right? I know DC is huge on EPSDT. They've got a decree on their plans to do EPSDT. So, and out of population health, if you look at what is it called, the S-shift, diabetes, we're gonna do something around behavioral health, we're gonna do something around opioids, whatever that is, roll those HEDIS measures into that. So it's all aligned. So even when we're down to seeing a good doctor here sitting in her practice, she didn't have to figure out who's in what plan. She knows, or doctors know, oops, I gotta do this. If I'm in Maryland, everybody gets this.
I think we'd be doing a service if we had the public health leaders. But like, you guys are informing the way that medical plans get measured.
Yeah. That would be
probably like, that'd be a big enhancement.
Yeah.
Where we are.
You're right. You're right.
So that's something that we can take back to the executive group to figure out how do we track and incorporate that into this. There's certainly a great deal of activity in this space, and we want to make sure that we're working in tandem. So appreciate that feedback.
Then we're giving them a solid if we're amplifying.
Right.
You know, their.
You know why that's also important, evaluate care. Evaluate care is paying the docs, with the quality measures and so all that belongs.
Maryland should be the most advanced state about this care by a lot because of the rate.
Kind of thing, we're talking about health care and public health, and they're obviously intertwined. They're quite separate in Maryland.
But
And to be aspirational,
Mm.
there's a lot of work to do, and maybe that's what you're talking about. But they're
the
very
whole-
different systems.
The nature of the delivery system across the country is shifting toward value-based care, or you know, sort of these new models for incenting providers based on what public health has been working on forever. So
I'm just gonna disagree.
It's very
That-
slow.
That's what you want to hear, but that's not actually what's happening.
in Maryland, it's better than everywhere in the country. And that's saying what it is, but theoretically, MCOs are value-based care, like they are supposed to be doing this stuff. They have all the.
Yeah. So at the risk of cutting off this great dialogue, I do want to make sure that we move forward for Ben to be able to present. So the last thing I want to say on this slide is just making sure that the work groups and their members get the assessment questions in by the 21st so that we can get those moving forward. Next slide.
I should say, so I think what Chris was raising and what did emphasize was that there are really important processes in play right now that are coming up in the next 12 months to some kind of decision on quality measures or on ahead or on the state health improvement plan. And the secretary wasn't completely clear on when, those processes are going to come to some interim, but we need to know that and start aligning our work with these external forces because they're really germane to what our report's going to be all about. So that's, I think that's what you were. And I think we can align too.
Yeah.
Like this timeline will be interim. Right. Right.
Especially factoring them in terms of recommendations.
Yeah. So
Yeah.
it's not just about our own assessment that we're
Yeah.
doing, but it's this external environment
Yeah.
of all this that's going on. Okay.
Yes.
We had the site visit in Hagerstown at Washington County on the 23rd. That went really well. I appreciate the health department staff and Earl for hosting us. We did get a couple of reporters who covered that listening session, and so I think that has helped raise some awareness. There are currently 7 comments that have been submitted online, and our next site visit at Howard County is on the 13th. They have shared that 24 people are already registered to speak. So we are seeing some increases in engagement and interest there. And my final update on this slide is that I've chatted with the Baltimore City Health Department team, and we're looking between September 9th and 20th on hosting something at their facilities. So they're hopeful that they can get that nailed down in the next couple of weeks, and we'll be able to publish that. So.
All right.
Was there any in-person?
Keep going.
Yes.
people at the house?
Presentation.
Washington County.
Washington County, you mentioned the 7 online comments.
We had, I think 3 or 4 different speakers and one super
Hold on to
twice.
speaker. I think Mina has the. Oh, they won't call you. No, if it's a Zoom, never mind. Yeah. She's in,
I don't know how.
intro.
Did you say your county or the county, or was it Washington County that did the promotion of the local?
Washington County, all the that's for sharing things that around Washington County and the Western, their health partners.
And their community-based partners. We've been promoting a lot on social media, and we've made flyers, templates that can be printed and posted.
Yeah.
Western.
Yes.
The legislature is out, and
Yeah.
thank goodness delegate
Yeah.
emails here. It's really important that the local delegation gets invited,
Yeah.
right?
Yeah.
I mean, maybe they are. I don't know. I don't know.
I'm going to jump in now. I'm so sorry because we have our presenter lined up. If we can save these discussions, if we have a few minutes after our presentations lined up, but let's respect, please, our next presenter. So thank you so much, Shane, for the excellent updates. Now I'm going to invite Mina to please give a brief intro, on our next speaker. So,
Everybody, I think, Ben, Stefan is a well-known and recognized figure in Maryland, advocating and understanding the health system needs of Maryland. He's, through his work as executive director of the Maryland Healthcare Commission, he leads efforts in the state to increase access to healthcare and address healthcare in Maryland, including primary care investments, which I know is something we've been talking about quite a bit today. He was previously director of the Center for Information Services and Analysis of the MHCC, and a prior budget analyst with the Federal Congressional Budget Office as well. But my favorite in your history of work is that you are also a former Peace Corps volunteer in Nepal. And that is one of the places I would love to visit. So I just really appreciate everything that you've done for public health and healthcare and the people of Maryland and through your illustrious career. And we're eager to hear about the work of the MHC.
Thank you. Thank you so much for the intro, Mina. All righty. So, Ben, you have
I have the floor.
Yes,
Okay,
you
very
do.
good. Thank you very much.
Sure.
I see a lot of friends there. I was impressed. Because I like two things I wanted to share with you before I start. One is I'm inspired by commencement addresses. I have to admit I've listened to Stephen Jobs' commencement at Stanford a half dozen times. I also like Admiral McRaven's commencement address at Texas from a few years back, and I have Ken Burns' commencement address from Brandeis earlier this year that I plan to listen to. So I'm going to add Laura's to the list of commencements I really like. But getting me into the presentation, the commencement address I really like is a commencement that was given by Ed Ellinger, former Minnesota Commissioner of Health, that he gave to the School of Public Health at Minnesota about 2011 or 2012. It's really quite inspiring, and he put the real mark on what it means to be a public health professional. If you have never caught it, send me an email. I'll send you the link to it. I'm going to go through this pretty fast today. If we can go to the next slide. Many of you know the Healthcare Commission work pretty well. What we're going to cover is, first off, I thought the first topic was the primary care investment work. We'll also talk about our behavioral health workforce assessment responsibility, our roles in healthcare information. I have some thoughts on that. And also areas in which we've increasingly or continually played a role, which is assessing the adequate of healthcare practitioner payment. And lastly, touching on our health planning and roles in reproductive health legislation that was passed in 2023, which is now rolling in effective with the June 1st deadline for health information exchanges and EHNs to be able to filter reproductive health information defined by the state. If we can go to the next slide, please. So I think many of you know us. I'm not going to really go through all of this, but we are a 15-member commission. I'm the executive director staff. The staff's 55 members. Hasn't changed too much, and our focus has not changed, although the particular missions have evolved over the last 20 years. I'll certainly agree with that. And we don't see ourselves necessarily as a public health organization. We're not defined as a public health organization in Maryland government, but we touch on key functions of public health repeatedly and an ongoing basis in our work. And I think, as you'll see today, if you don't know, that we definitely behave as a public health organization oftentimes. Next slide. So we see it in terms of our actual functioning roles. We see ourselves as we plan for health facility development. We measure and aggregate cost and quality data. We really focus on enabling healthcare information technology. We see ourselves as being very close to all stakeholders, particularly consumers and purchasers. And we've recently and on an ongoing basis served as a assessor of health policy options for the legislature and other policymakers here in the state. We go to the next slide, please. The organization, a previous executive director had worked at NIH. His vision was to organize it much like NIH is. And if you recall, NIH has multiple centers. 55 people don't necessarily convert to even one center at NIH, but the concept is somewhat the same in that each of the centers has defined functions. The information systems group focuses on the all-payer claim development, and more recently, the collection of non-claim data generated through value-based purchasing arrangements, as well as price transparency. We have a center dedicated to quality measurement. In particular, we have a very expansive quality reporting initiative aimed at enabling consumers to make wise decisions when they select healthcare services. We also, that group is also heading up our efforts to raise awareness on health disparities. Our Health Facility Planning Center is the arm that handles our principal responsibility in health planning. It is what I call the existential responsibility of the commission, is to determine facilities that may be expanded, changed, or modified, acquired, or closed. And certainly it is one that we take very seriously. And lastly, an area that is increasingly growing from 2010 onward is our Center for Health Information Technology. We work closely with CRISP, not only as the organization that designates the state designated health information exchange, but promoting capabilities of CRISP, as well as highlighting the role that it plays broadly, not only in care delivery, but as well as in public health. And here too, we work, that group is principally responsible for evaluating the primary care investment alternatives, which I'll talk to later. Next slide, please. So the Healthcare Commission, and I do note that in the audience, former Commissioner Fran Phillips is in attendance. And what I would say is she may recall that we go through a 4-year assessment and establish new strategic priorities or modify those that we've already established. I think that these priorities align well with the objectives of the Health Secretary and the Moore administration. I note that these are broad, visionary priorities, and we do try to define them in more specific and targeted measurable outcomes through our work, through requirements such as the managing for result requirements that all state agencies are responsible for. And we try to tie these broad priorities to what we are doing on an ongoing basis through our budget, through the allowances that we receive from the governor and approved by the legislature. Next slide, please. So the first area I want to really talk on is one that was highlighted when the secretary spoke with you, and that is in 2022, we were given authority to convene a primary care investment work group. The rationale for that in the legislature was that there's strong evidence that, of course, primary care yields improved outcomes in particular, lower cost. There's recognition that in the U.S. compared to our other comparable countries in the OECD, we are horrendously underfunding primary care. On average, we know that primary care spending accounts for only about 7% of total spending, as opposed to a level about double that in other developed OECD countries. Simultaneously, per capita spending is, of course, twice what we see in peer countries, and we can't demonstrate superior health outcomes for this increased investments. For a long time, primary care experts have been able to demonstrate that increased investment in primary care is beneficial for quality of life, access to care, mortality, and general patient satisfaction with the care they're receiving. This is all not new, but it's important to understand that I think increasingly elected leaders recognize the importance of investments in primary care. Next slide, please. So in 2023 was the first year that we began to work with a work group representing different stakeholders in the delivery of primary care. We convened a work group. The principal role was to make some recommendations, ultimately on the level of primary care spending in Maryland. The work group started out with the perception that it should rely to start with work that had been done by the Milbank Foundation and the Primary Care Collaborative that had been working with a number of states, and we became close partners with Milbank as well as PCC throughout this endeavor, and concluded that we would build a investment formula that really built off what Milbank and other states were doing. Our formula really aligns quite well with what other states, particularly states in the Northeast, as well as Delaware, are doing nearby. We released our first report in December of 2023, somewhat of a complication, but I think a basis for stirring some debate was the release of the notice of funding opportunities, euphemistically the AHEAD model procurement, which the secretary talked about, came out in December of 2023. What was a bit surprising was that AHEAD in their solicitation did note that they were proposing a definition of primary care, which was considerably broader than what the Milbank Foundation, the PCC had thought about, and what MHCC and our primary care investment work group had considered, in that it broadly considered services provided by OBGYNs and behavioral health providers, regardless of whether they are directly affiliated with primary care practices or not. That differs from what the work group had proposed, which did recognize that when OBGYN services were provided in primary care practices, they counted towards the primary care investment targets. When behavioral health providers were embedded within primary care practices, they counted, but when they operated independently, they were not included. So there was a significant difference in those categories of how those services were treated. We're still evolving that, as you'll see, but they do make a pretty big difference. And I think over the next 6 months to a year, we'll have to tease that out in terms of which one we're going to move forward with. There are a few options on how that can be done, but it's important to emphasize that it's different. We can move to the next slide. This is your presentation eye exam. It's for your use later on, not today, but this details in some degree of explanation the differences between the primary care investment group of primary care and the AHEAD model definition of primary care. One other note, in addition to directly incorporating OBGYN as a specialty and behavioral health as a specialty, it shifted from using the taxonomy codes that had been established by CMS as a result of the establishment of HIPAA nearly 2 decades ago, and went back to defining providers based on specialty code, which is an older definitional approach to categorizing providers, one that we think is not quite as precise, but is probably more universally understood, as it's used not only by the federal government, but by licensing boards across the country as well. So if we can jump to the next slide. And to really drive home this point, in your presentation packet, I did provide some detailed information on these comparisons, broken out in the case of private payers by how much variation there is in the 5 leading commercial insurers in the state. I thought it would make this a little too complicated for the brief presentation today, but you can see on the far left at the top table, the primary care investment share of total medical spend is shown. And next is the head model spend. And you can say it's about 2% difference owing to the broader definition of primary care that would be used between the 2 definitions. In terms of what does that mean between on a per member per month spend, the lower table does show for the PCIW definition and the AHEAD definition differences. Again, note that the principal driver is the broader inclusion of specialties that are not included in the PCIW definition. Now, there's also some differences in the CPT and HCPCS codes that are used. You'll note that we report the number of CPT codes that are referenced in our formula, and in the CMMI definition, they're somewhat broader as well. Next slide, a comparable slide is shown for, move to the next slide to, I think it's Medicare will show up next. And as you might expect, this is traditional Medicare. Total spending per capita is of course higher for a Medicare beneficiary than it is for someone who's commercially insured, owing to their greater healthcare needs. Therefore, the percent primary care shrinks. Still, when you look at it by the per capita figures, which are spending per member per month, show that actually the spending levels are quite similar between the commercial population and the Medicare population, and it ranges between $20 to $40 PMPM. The differences, are again quite substantial between the 2 definitions. And if we go to the next slide, we'll see one that guess we don't have that. I don't think we must have dropped out the Medicare Advantage comparison, which did fall between the commercially insured population and the Medicare, traditional Medicare system spending levels. And, we haven't really looked at the Medicare Advantage program as a state as much as we should start to, because as many of you know, Medicare Advantage now counts for almost 25% of the Medicare beneficiary population in the state, considerably lower than what is seen in other parts of the country. Pennsylvania, for example, has a 50% Medicare Advantage population. So a few takeaways from this, and I did bring in Medicare Advantage here. The spending levels, the percentage of spend highest, of course, in the commercial market, declining as we move from Medicare Advantage to traditional Medicare. But there are significant differences as we move into considering putting these formulas into the AHEAD model, should we be successful. So I think that's going to be an important question as we think about implementation, not only implementation, but the optics about how much should be spent in primary care. The first recommendation the commission made through the work group, primary care work group, was that we should move towards spending 10% of healthcare spending on primary care by 2030, with the goal of 1% per year. Now, if we use the AHEAD formula, one might argue that we're damn close already. And we would obviously want to rethink it if we're including a broader swath of healthcare providers in that formula. But it also might create the impression, particularly among the commercial payers, that, geez, our work is almost all done. We're pretty close to achieving the goals set by the state. So I think we have to look at this carefully. What I would say is that although targets might differ, I think it would be beneficial if we could agree across all payers on what our definition of primary care was, because it's going to be extremely confusing, I think, for providers to understand if they're in or out of those formulas. So stay tuned. I think we have heard from CMMI that they are strongly committed to their definition. We'll take some guidance from them, but I think the Healthcare Commission wants to do what's best for moving the state forward in advancing primary care. So although we've come up with a definition based on what other states and the consensus work group felt was desirable, I think we should all be open and flexible to consider what would be best as a uniform measure across all insured populations. Next slide. The next area that I wanted to present briefly on was an area that I know Delegate Bagnell worked closely on, and that is the workforce assessment study. It actually passed in 2022. Sorry for the 2023, excuse me. And it established a behavioral health workforce investment fund to provide reimbursement for costs associated with the education and certification of additional behavioral health professionals and paraprofessionals. It directed the Healthcare Commission to conduct a behavioral health workforce assessment and present the findings to that by October of 2024. We awarded a contract with a lot of input from behavioral health stakeholders to an organization based in California called Trailhead Strategies. They had done what we thought was a very comprehensive report for the county of San Diego in California. With some trepidation, California is a lot different in the delivery system than Maryland, but we had received so many recommendations about their work that we went ahead and awarded a contract to them. Up to this date, we've not been disappointed. And if I'm going to show you some of their initial findings that they presented to the Commission on Behavioral Health Access and Availability last week. So you go to the next slide, please. And this kind of lays out for those that really want to know the nuts and bolts of this. Move up. There we go. This lists how they determined from the data sources they were using the SOC codes that are going to be used in defining what they defined as core behavioral health occupations, behavioral behavioral health occupations that came through a pathway through nursing, and related occupations that are oftentimes engaged in the delivery of behavioral health services. Next slide, please. This is their preliminary estimate for Maryland in 2023. They using largely, I want to emphasize this, that we've talked a lot about the boards. We are largely using federal data sources and some proprietary data sources for this analysis. The boards have a lot of potential, but oftentimes we have difficulty determining whether individual providers are actively engaged in patient care or not. So we opted to go a different direction, one in which our consultant felt very confident. And this lists out their estimate of about 31,000 behavioral health professionals in the state in all occupations. The chart on the right breaks those out, and you can see that substance abuse and behavioral health counselors and therapists, followed by social and human services assistants, as defined by those codes, represented almost half of the behavioral health workforce in the state. You'll also note that I think one of the things that we have questioned is, particularly as it relates to psychiatrists, but to psychologists as well, the fact that they seldom participate in payer networks does mean that access is even more limited than it appears from the actual body counts that you get. That these are individuals that are engaged in patient care, but if you're not in a payer network, many of the insured population are not going to be able to seek care. Next slide. This provides a more detailed breakout of healthcare professionals. And again, we're using the overall number as opposed to breaking them out by what we have done in the past, which looked at licensed behavioral health professionals. We're talking about now the entire workforce overall, and the workers per thousand does range considerably between Baltimore City and some of the rural parts of Maryland, southern and western Maryland. You'll note that this is something I just saw earlier today. Our consultant did group Montgomery and Prince George's County in southern Maryland. I think I will get some quibbling about that from colleagues in those two jurisdictions. Typically, we carve them out as national capital area, but for it will be corrected in the final report. But it does group them in southern Maryland today for this presentation. Next slide, please. So a few takeaways from what our consultants have found. Low wages are a big concern, and we're going to talk about that later. That they concluded that only about 75, I think concluded that approximately 75% of behavioral health professionals make less than a living wage. A living wage is what is, it's not, some people are going to jump to the federal poverty line. It's considerably higher than that. I did check before we got started today. It's really a metric that is developed by some academic institutions, MIT, and it is the salary that is needed to reasonably care for and clothe a family. It turns out that for Baltimore City, for example, the estimate is that a living wage for one person fully employed full-time, it would require for that person living alone a wage of approximately $32 an hour. With one dependent, it would jump to $42 an hour. So considerably higher than the minimum wage in Maryland, considerably higher than than a wage that will be translated by the federal poverty line. I would say if you want to think about this, this would probably fall between 300 and 400% of the FPL, federal poverty line. Now the FPL is nationally scaled. It doesn't reflect local cost of living. The living wage does. So just for clarification on that, it's not a term that we see a lot of, but I think it's actually a pretty useful metric. 90% of the substance abuse and mental health counselors, therapists, and social workers actually make a living wage for a single adult and a dependent of $86,000 a year. We know that providers of color are not as likely to be in the behavioral workforce overall, and that's what our consultant found as well. Also, when they are represented, they tend to be represented in lower paying positions and much underrepresented in the position psychiatry and psychology, for example. Overall, among the prescribers, which are largely psychiatrists, 72% are white or Asian, compared, of course, in Maryland to that 55% of the overall population is white or Asian, and the majority of behavioral health workforce is female, except for psychiatrists. Next slide. So our consultants have estimated that approximately 22% of the Maryland population translates into about 1.4 million people are in need of behavioral health services. Good news is, according to their estimates, and those are based on SAMHSA data, about 63% receive treatment. However, nearly more than a third, 37%, or about 500,000 people, did not receive treatment. These are based on national numbers, and we certainly are going to socialize this information to determine if these estimates derived from national numbers really align with the local experience moving forward. Move to the next slide, please. So the other area is a focus. We wanted our consultants to examine some other behavioral health investment programs around the country. They highlighted 4. I'm not going to go into any detail on these, given we are at 20 to 5, but point out to you at your leisure, review the additional slides. There's 1 slide per each of these initiatives. And I think number 1, they are a little different in where they focus in the behavioral health training pipeline. But they do demonstrate that it is possible at a state level to make the kinds of investments that are needed to strengthen the behavioral health workforce. Next slide, please. So tied into this is the responsibilities that the Healthcare Commission has exercised traditionally, which is to examine payment adequacy. In 2022, we were directed to come up with recommendations on continuation of telehealth. Most commonly, telehealth post-pandemic has remained very heavily used in behavioral health, but in other somatic care as well. Throughout the pandemic, behavioral or telehealth was reimbursed at the same level as in-person care. Those waivers that applied both to the commercial, Medicare, and Medicaid markets have continued, but there is growing momentum to reconsider that. We were directed to look at what would be appropriate. We are working with a consultant currently to come up with recommendations on what the level of reimbursement should be for telehealth services delivered both for behavioral and somatic care, as well as more broadly appropriate payment levels for behavioral health more generally. We typically benchmark payments to what we consider a transparent and fair fee schedule, which is the Medicare physician fee schedule. There's been quite a bit of concern raised by behavioral health professionals in particular about adequate payments under Medicare. The Medicare Payment Advisory Commission does do adequacy studies on the Medicare fee schedule and generally judges that the fee schedule is adequate. I would note, however, that as we move increasingly into value-based payment, as there are budget neutrality requirements in many of the payment initiatives at the federal level, the way in which we can foster value-based payments is to achieve budget neutrality by reducing the Medicare fee schedule. For example, the fees schedule was in 2024 was reduced by 3%. So there's concern about that. I think we are going to be focusing on both telehealth generally and behavioral health. One thing that has affected this recommendation somewhat is signals from Medicare, or CMS rather, that they intend to keep the temporary waivers on telehealth services for a bit longer. That may shape our recommendation for how commercial and commercial payers ought to respond as well. There's also considerable question about the reimbursement level for what's called audio-only care. That has been endorsed, was heavily endorsed and used during the pandemic, reduced to some degree as technical capabilities in physician practices have grown, as well as technical capabilities of patients. But I do have some concerns about audio only. It seems popular, but we have very little outcome data on the impact relative to audio, video, telehealth, or face-to-face visits overall. I think we need to have that information in hand before we reach any final conclusions on whether we would judge audio only equivalent to audio and video telehealth services. Next slide, please. I also want to touch on data is essential for public health, and I would emphasize that the Healthcare Commission has been collecting and developing the all-payer claim database for nearly 2 decades now. We are making that data available to a wide variety of state partners and share that with the School of Public Health at Maryland as well as Johns Hopkins. But we've increasingly recognized that we have to think of alternatives other than simply releasing data to qualified applicants. Like the federal government, the concept of data archives are taking roots in Maryland, and it may be a vehicle through which we could provide wider access to organizations that don't have capabilities to house the volume of data that's in the all-payer claim database. Keep in mind that the all-payer claim data systems are visualized as population-wide data systems. But over the last 5 years, we've had recent challenges, principally because of actions that have occurred at the federal government level. The decision by the Supreme Court in 2015 led to the court ruling that self-insured private employers could not be compelled to submit data to state all-payer claim databases, which meant that the commercial component of the all-payer claim database in Maryland was reduced by about 45%. A similar reduction was incurred not similar, but complementing that, the federal government itself through the Office of Program Management, the federal government's employee Human Resources Department concluded that if ERISA plans were not affected, OPM had a similar statute, and they concluded they too would not contribute data to state APCDs. In Maryland, 400,000 federal employees, dependents, and retirees were taken out of the APCD as a result. We are working through CMS with trying to get the federal employee data back, but have not succeeded as of yet. And at the same time, we're recognizing that the claims, which are often termed the exhaust fumes of the healthcare system, are diminishing in importance as we move to value-based payments, where claims may not be fully descriptive of the reimbursement that an individual provider is giving. So we are moving forward with collecting non-claim based information from payers. Our first report was released in November of 2023. The picture on non-claim based payments is very preliminary at this point, but it's going to be a growing component of researchers who want to look at what the total spend is for healthcare services. Next slide. And I did want to point out that the APCD is not directly accessible. We're looking at some options for making it available through Tableau type dashboards. At your leisure, click on the test site link. It has recent data. We haven't updated it for our most recent information, but certainly feel free to look at it and let me know. Next slide, please. I'm going to talk briefly about our quality reporting website. It is a comprehensive site aimed at providing information to consumers across the entire scope of services delivered in Maryland hospital, nursing home, assisted living, home health, hospice. For many of those categories of service, important quality metrics are available. Like much of healthcare information, providing information to consumers is a challenging role, and we recognize the challenges that it takes on. But we would encourage our colleagues in public health to certainly make that available through your information channels. We think this is important for consumers. It's never the only site, the only source of information, but it supplements information that may be available through family members, provided by healthcare practitioners. And we emphasize, although not a single source, an important independent source of information on quality and performance of healthcare providers. Next slide, please. This is a splash screen that you'll see. Also, the URL listed above and the categories of service are listed below. Each of them has information specific to those provider categories. Next slide.
Sorry, I'm just going to comment. If we can round up in 3 minutes so that we have enough time for questions, especially if I don't want people to log off. Thank you. Sorry.
Okay, I'm going to jump past this now and probably if we can go to the next slide. Next slide. And you talk about the work that we're doing in implementing House Bill 812, which is the reproductive health legislation that was passed in 2023. It requires the health department and MHC to work together to adopt regulations to support implementation of a law that would require health information exchanges and electronic health networks, electronic clearinghouses to screen certain reproductive health information as information generally flows through the information infrastructure. A commission was also established to determine and make recommendations on additional information that should be filtered. Right now, the big focus is on gender affirming care, but nothing formally has been adopted. We are encouraging the commission to let's focus on reproductive health information. First, an important milestone was met 4 days ago. Beginning June 1st, we have the ability to find health information exchanges and electronic health networks, clearinghouses, if you will. If they're not doing this, this is going to be a slow implementation. We got requirements on the capabilities of these entities on last Friday. Many will be requesting waiver on some part of the regulations, but we are committed to working very intensely with these networks because we think this is an important priority here in Maryland. Certainly, the concern is with people coming into the state to receive legally permitted healthcare services here that may be in jeopardy in their home states. But we think there's also some concern among just us residents of our own state that do want this information shielded or have the ability to control it. And this is an important step moving forward. Happy to answer questions from the commission. Sorry for taking so long.
No, this is so important. This is important. Thank you so much. So does that conclude?
That concludes it. I will end with let me think here. So I will end with a comment, as did Secretary Herrera Scott, and I'll borrow it from one of my commencement addresses, taking it from Admiral McRaven. Make your bed. It's a good.
That's a good one. Thank you so much.
So happy to take questions if any.
Yes, please. We have members online and members in the room for questions. Jane Drummond, please.
Yeah, hi, how are you? I'm sorry, I had to. But thank you so much. It was thank you, first of all, for all of your public service to the state. That's the first thing that I want to.
So I think you're frozen.
Can you hear me? Okay, how about now?
Yes, I can hear you now.
Okay, good. I'm sorry for that. Okay, so thank you so much. It was a really broad overview. Kind of have a couple of questions. Really appreciate you talking about just kind of the primary care investments early on. But one, how do you think the impact of the new requirement from CMMI to make sure that Medicaid members are going to be able to be seen on a primary care or OB or behavioral health within 10 to 15 days? So I'm just kind of interested in hearing your thoughts around that and the integration, of course, the AHEAD model. We're anticipating that we're going to get that. So that's one. Two, I didn't hear a lot about health equity in your presentation. And I'm just kind of curious, that's always on the top of my mind, in how do we really be super intentional about, the equity. I did hear the workforce, the report that the workforce gave and minorities, and we know trust and just provider concadience. Just so I'm interested in, just as you being certainly a leader in developing our healthcare systems in the state of Maryland, your thinking around integrating and ensuring we're pushing the levers to drive equity. So those two kinds of things.
So first on the Medicaid, I think the key is, do we have the MCO networks, are they adequate? I think you can make established requirements, but we really need to have a better I think that Dr. Herrera Scott really emphasized a point that I think everyone probably understands. It's darn hard to really fairly assess networks, especially when you consider culturally appropriate care, which we're recognizing, is increasingly a key factor in why people don't seek care. And it's not only having the providers, but having the right type of providers. I think it's a very important step. Two, I did kind of skip over one area which we are working on, which is we are, as I noted, the health planning entity for the state. It should say the health planning for facilities and services, because the secretary talked about the broader state health plan that is really looking at the entire scope of capabilities and requirements that are needed to have a fully functioning service. But what we've done is we've added a requirement for organizations that come forward to the Healthcare Commission that want to add services, that they document how they would address health disparities or how this particular project would do that. That's an important step. Keep in mind that we have historically had that as a requirement. I point to in our cardiac services activities, we typically will add a requirement or enforce a requirement that they demonstrate how they are engaging and reaching out to underserved communities. Importantly, even though the CON for cardiac surgery to Suburban was awarded nearly 2 decades ago, they are still reporting on how they are outreaching to communities in Prince George's County where cardiac services are scarcely available. Two, through the work that we do in reporting on quality, we are looking at breaking out some of our reporting to the extent we can by race and ethnicity. I hope to share with you a CAHPS set of consumer scores on satisfaction today. It's not quite ready, but we are trying to break out consumer satisfaction by race and ethnicity. And we are working closely with the department on this report, maternal health and infant mortality report card that was established in the 2024 section of the legislature that the secretary also talked with you about. So those are a couple areas.
Wow.
Yeah.
Great. Thank you so much. Please, I would definitely love to see those 3 reports that you just mentioned. So if those can be added in, that we'll follow up and receive those. Thank you so very much. All right, I'm done.
Thank you, Jane, and thank you, Ben.
Yes.
Wonderful. Thank you. I just wanted to note that we have 2 more minutes until the end of our meeting today. However, it's important that we note that, because I know we have people online and people in the room. Please note that you're not compelled to stay after 5 p.m. If you would please permit us to go a little over, 10 minutes, if you can please stay back. We just want to make sure that, because we have other important things to touch on, 3 other items on the agenda, which includes work group updates, announcements, and then we adjourn the meeting. Please, if you have additional questions for Ben, kindly send them to us as an email. We'll be very happy to forward to Ben. On this note, I will now have Chidubem proceed with the slide. Thank you. Thank you so much. Please.
Thank you very much.
Thank you so much. We really appreciate you. Thank you. Appreciate it. So, right. So here, the model here, for those that are on, in June, we tasked each of our work groups to share additional assessment questions in addition to what they had provided previously. Those questions were really like taking deeper dive into the items specified in the legislation, especially focusing on the foundational public health capabilities and areas, and then focusing on the parts that the legislation points to that we need to make recommendations on. So that's really what it is. Take time and look at this model. The model is widely used and recognized in public health. It's based on good principles of good practice, sound professional judgment, and large body of systematic research. So that's it. And next slide, please. So now we would have, I don't know if we have a representative from Communications and Public Engagement Work Group.
Hi.
Thank you. Thank you so much.
Yep, no problem. Tony had to jump for another call, so I'll just provide really quick updates. We're in very good shape getting our assessment questions finalized. We received our last round of feedback at the end of last week, had a planning meeting with the co-chairs on Monday, and we're compiling everything, and we'll share that back out with the rest of the work group, and we will be all set. So if you needed any other information, Tosin, please let me know. Otherwise, I'll give the floor back to other people.
Thank you so much. Thank you. All righty. Next is data and IT. And just to chime in, just want to make sure, in case people are not aware, this is the stage where we're finalizing our assessment questions. What groups have until June 21st, right, to send all the final questions in. You've heard from Jane about the timeline, so we're really looking at the questions. So, you know, in case you're online, so make sure you communicate with your work group in terms of, you know, sending those questions in, but making sure you go by the timeline, right, for your work, because they need time to review. All right, thank you. And I think Dr. Matt Levy presenting for data and IT. Thank you. Or representative from the team.
Good afternoon, everyone. We are in good shape too. We are working on our final revisions of our assessment. We met yesterday to go through the entire group, and we have a subcommittee that's working on them as well. So we hope to have them revised over the next few days, and we'll be sending them up as soon as they're done.
Awesome, awesome. Do you have like certain themes that your questions were around, just to, you know, just touch on it briefly?
Well, I mean, it's sort of one of them is one of the big themes is that, you know, UEHR capabilities. But when we started to pull it apart a little bit, you know, it sort of broke it down into what functions of a local health, what are the functions of a local health department, and what systems do they use. And some health departments use, you know, 50 to 100 different systems.
Yeah.
And the other big, I think the other big theme was how do they function together? How do they work together to create efficiencies? And we talked a lot about efficiency in our data systems and technology during the meeting as well. So those are a couple of the themes that came up.
Very key areas. Thank you so much. And again, you know, this recording is always available online, so people can go through the slides to pull some of those questions that the presenters are talking about. All right, next is funding work group.
Good afternoon, everybody. We did submit some questions. I'm not sure there'll be any revisions to those going forward, but I think the questions that we submitted are fairly comprehensive. We continue to hear presentations from various levels. We've had detailed presentations on public health funding at the state level, at local level, separate presentations specifically on core funding. We had an academic presentation on community benefit spending from staff at Johns Hopkins School of Public Health, a separate presentation on community benefit spending from staff at the Maryland Hospital Association in this past month, more community benefit spending discussion from staff at the HSCRC. Our meeting in June, which is coming up, I think, in about a week and a half, we're going to turn our attention to potential funding sources in the private sector, including philanthropic groups in Maryland. And then I think at that point, we will be ready to start with recommendations.
Fantastic. Thank you so much for your work. Thank you. All right, next is governance and organizational capability. And we have Fran here in the room. All right. Themes, yeah.
That reflect our assessment questions. And I guess I just want to break the very last slide where we are beginning to coalesce around some potential recommendation areas. They're not specific recommendations, but one, we think that there's a need for more definition in order to define accountability. It's a little ambiguous governance when we've got a shared model between the state and the locals. And so who does what is kind of complicated. And so we want to unravel that and make some recommendations once we kind of drill down a little bit more. We also think that there's a real need for much more advanced professional development and orientation for public health leaders, either at the state level or at local levels. You know, they come in as health officers, they don't know, they have brilliant clinical backgrounds, but this is a whole different environment. So what's the orientation and what are the opportunities for ongoing professional development for leadership, not necessarily just the top leader, but to really invest in our people, and that has huge implications, not just like for workforce and for our competitive recruitment, but also for the quality of governance. The last thing I'll say is there's been ambiguity expressed, I think, here previously about legal representation of local health departments, whether that goes through the state attorney general's office or it goes through the local county office of law. So we need clarification on that for sure. So we're going to just distill these recommendations a little bit more and get back with you. One thing I will say to the other work groups is that we would like to emphasize with you all more, because from a governance standpoint, we really feel that we want to be much more familiar with what all of you are doing, thinking in your work group areas. So we're going to look for opportunities to have some joint meetings because we're real super interested in hearing about your views on some of this.
And also thank you so much, Fran. Thank you for the update. Just to note, before we begin the assessments, you know, in totality, we will have the opportunity of also sharing, right, the finalized tool, right, the questions with the, you know, with the work group members. So people will have the opportunity to see. All right, next, and I guess the last group is workforce.
Workforce, I'll be brief. We had a very productive meeting a few days ago. We were sort of discussing this with background about how productive that meeting was. I think part of the goal of that meeting was actually to break up what is a large working group into smaller subsections. It was our first time to do breakout rooms. And I think this was a recommendation that sort of came up. It allowed everybody to be engaged, right? We sort of all felt it. And we came up with not only a vibrant discussion of sort of potential focus group participants, potential key informants that should be asked, but also the questions that came with it in 4 different areas. One was identifying diversity of the public health workforce. The other one was looking at talent development pipelines, recruitment, retention, and onboarding. The third group was looking at the workforce in context of fundamental public health areas, especially access to behavioral and primary care. And the last was dealing with improving the medical reserve corps. So we have those questions, I think, in draft form right now, but they will be submitted in time. Thank you.
Thank you so much, Bruce. Wonderful. All righty. Next is announcements. And after that, we would end the meeting. So few announcements here. You can also find them online. Our next meeting is on July 11th from 2 to 5 p.m. and it's going to be at Prince George's County Health Department with a virtual option. That's the first time we're transitioning from here. We'll share more information about that, and again, check on our website for more updates. Again, it has a virtual option. So upcoming, we have Central Maryland Regional Public Listening Session at Howard County on June 13, 5 p.m. All right, so that's coming up, and as mentioned earlier, right? And we also have the public. Go ahead, Mina. I'm sorry, more. The site visit, yes, the site visit, and yes, absolutely, and the public listening session. So we're looking forward to that, and thank you so much for hosting us. So we look forward to that. There will be some flyers about that we'll be sharing online. Please, when you see them, make sure you share. Please share, okay? All right. So I've already talked about the deadline for work groups to submit their questions, so I won't talk about that. Again, it's June 21st. All right. Last item on the agenda. Please, can I get a motion to adjourn the meeting? Maura moves, and they'll be back no seconds. Thank you so much. This has been awesome. Just want to say thank you for joining. We look forward to seeing you in Prince George's County if you can come in person. If not, join the link online. Thank you so much for your engagement. All righty. And meeting is ending at 5:10 p.m. Thank you. Bye-bye. All right. Thank you.